Very good morning to all of you, especially biases. I like very much the topics and the speakers and the knowledge they have, and they are very thorough. And regarding Durga, she is my friend's sister's daughter. Recently, I was informed. Dr. Shakuntala was my colleague, and she is the best friend of mine by Visakhapatnam. And regarding Durga, she is a specialist in reproductive medicine and minimally invasive surgery with over 18 years of work experience in this field. She is responsible for bringing the most advanced ART treatment at Oasis. With her experience, competence and personalized approach towards every patient, she is now leading Oasis in the fertility industry. Prior to Oasis, Dr. Durga practiced in the United Kingdom and Canada. She underwent her professional training in UK and has several papers and publications to her credit during this period. She was the pioneer in research and practice of in vitro maturation treatment and fertility preservation in the prestigious McGill University in Canada. She has conducted and attended several conferences across the world and also presented her research findings in several hospitals. She invited us for many of the IA workshops and conducted in the medical college, Pinamneni Siddhartha Medical College, so many, and also at her own center. And she gives a very clear-cut idea regarding whatever topic she is asked. And the PCOS is most importantly, this topic is a heterogeneous condition with metabolic disorder, endocrine pathology, mostly suffering with the menarche to menopause. She is going to talk on polycystic ovarian syndrome. Even though it was established in 1935 by Steen and Leventhal, lot of changes and modifications, lot of expansion in the etiology, so many things are happening. Now, I request Dr. Durga, congratulations for your achievements during last 1 year and also during 2 years of your life, and wish you all the best in future also. I think you will be a good, successful doctor.
Dr. Rao, thank you for the excellent introduction. I wish I was as high as you spoke about me. Yesterday, at this junction of 1 year of Vijayawada, we did tree plantation. Now you'll wonder why I'm talking about it. I'm talking about it because, when we are talking about us being as doctors, our first, I think, priority and our duties towards the society that we are living in. We said, fine, we have been 1 year in Vijayawada, we have offered services of fertility, what else can we do? Let's make Vijayawada green. Fine, that was done yesterday in terms of tree planting. But beyond that, before we become fertility specialists, we are gynecologists to start off with. And I think as gynecologists, there's a lot that we are doing, but I was looking at what else can we do. Now, Modi is talking about, Swachh Bharat. You speak to any physician and you talk and you ask them, what is the disease burden? What are you scared about in terms of the health risks to the population that we are looking at today? Diabetes. It has become such a problem. And I'm sure they can say that in another 10 or 20 years, at least 80% of the population will have the disease. So they are really looking at this, the abundance of where diabetes is actually taking the society. Now that is as far as a physician is concerned. But when we are looking as gynecologists, I think there are two conditions that come to my mind which are actually very scary. And I think the incidence keeps on increasing and we are not seeing a way of actually putting a stop to this. And the two things that come to me, and the chronicity of the problem is one, PCOS, and the second is endometriosis. Now when we are really looking at endometriosis, which Dr. Ashok will be discussing with you, it is not something that we can do a lot about. Yes, treat them appropriately, which you will be given guidance about. But I think when it comes to PCOS, our responsibility as a gynecologist, forget fertility, as a responsibility as a gynecologist is immense. And that is what I wanted to actually take you through. So what is PCOS? So we are really looking at this being a multifactorial and a multifaceted disease, and that is what is actually making it so difficult to actually control. What are we talking about and what is its impact? Uncontrolled ovarian steroidogenesis, which is coupled with aberrant insulin signaling and excessive oxidative stress. Now what is happening is every concept in medicine right now, there are two things that are actually actually causing a lot of associations. And the first thing everybody talks about now is a genetic evaluation and a genetic association with most of the things. And now the other thing that is coming across is the oxidative stress. Now this, unfortunately, is on a basis of genes as well as environment. But we still haven't understood this completely. So let us look at the pathogenesis at each level of the system. In the ovary, what happens? Well, there's an intrinsic defect in the theca cells, which actually causes the hyperandrogenemia. It doesn't leave the granulosa cell alone either. It causes a problem there, and that is the reason why you see such high levels of AMH when you see in PCOS. What tends to happen is, you're born with a certain number of oocytes, correct? We are told that we have about 50,000 to 1 lakh oocytes when they reach puberty, and slowly that is what gets deteriorated through their lifetime. But what happens in PCOS is the same number of follicles, the attrition is not the same. So what tends to happen is the follicle, the apoptosis is slightly lower. Insulin resistance. There's decreased insulin sensitivity. There's a receptor binding defect, again associated also with genetic expression. But what is important for us to know is that 80% of people with PCOS have insulin resistance. 95% of them are obese. Okay? But another thing that you will have to remember is that the lean PCO, at least have 65% of them having insulin resistance. So just because you see a thin woman, do not think that they don't have insulin resistance. It also causes disorder in the GnRH pulses. It suppresses the SHBG. It potentiates, therefore, the androgen production. And along with the high levels of LH, like I said, the follicles get arrested. Obviously, there is no development towards the ovulation and a dominant follicle. What about this oxidative stress? Well, what we have noticed is that there's a lot of glyco-oxidative stress on the cells, and this leads to mitochondrial dysfunction. And this could also be the reason sometimes when we are really looking at PCOS, even though you see ovulation, not all of them conceive, because we don't know the quality of the oocyte. The oocyte is developing in an area, in an environment of so much stress, so obviously it will affect the quality of the oocyte as well. Now again, the hyperandrogenism that you see in PCOS is also affecting the oxidative stress. You have the glycation end products which also are increased. There's also an inflammatory state which, unless I was actually reading through, we didn't realize that there's also a lot of inflammatory markers that are increased with PCOS. And what are the inflammatory markers that are increased? All the cytokines, the chemokines, the adipokines. How are they increased? Well, what tends to happen is the adipose tissue which is increased in PCOS, there's an altered morphology. And what tends to happen is there's a reduction in the vascularization, which again causes the hypoxia. That hypoxia causes the inflammatory markers to increase. And all of these inflammatory markers make the whole process worse. Genes. Why are we talking about genes and why did the concept come across? It came across because there's a familial aggregation of PCOS. But again, here, life hasn't been made easy. There's not just one gene where you can look at and say, fine, this woman may have PCOS. There's an aggregation and there's a cluster of these genes, which means that we are finding out more and more new genes that are being added on. So, how does it all work? You sit, you don't exercise, you eat fatty food, you drink, you smoke. What then happens? Obesity. Insulin resistance increases. That again causes hypertension, hyperandrogenism. Okay, in the reproductive age group, they conceive, there's placental disorders, there's hypoxia, and in this environment, the fetus grows. The fetus grows in all of this stress environment. So then what tends to happen is two things. Either it will be small for gestation, IUGR, or you'll also have, when you see in PCOS, you expect big weight babies, but even that is under stress. So you have neonates that are born under this environment of stress. What then tends to happen is this. We are now talking about all the things that can cause PCOS, correct? How do you detect it? Well, each different group has come up with their own concepts of diagnosing it. But as gynecologists, we are following the Rotterdam criteria. But a note of caution. Rotterdam criteria was established in 2003-2004. We are now in 17. There's at least about 13 years since the development of the criteria. Are we in the right place to actually just look at Rotterdam criteria? Probably not. But as yet, we don't have any other better criteria to diagnose. Why am I saying this? I'm saying this because we are talking about PCOS, we talk about insulin resistance, we talk about weight. We are even talking of AMH and its association and how you can diagnose PCO because of AMH. But none of these things are actually included in your diagnosis. So this is a thought that we have to look at. Now, the three different aspects that you look at when you're diagnosing PCOS is obviously hyperandrogenism. You see a woman walking into your clinic, you have an idea. This woman possibly could be PCOS. You tend to do blood levels, you probably will confirm your diagnosis. Menstrual irregularity, during your history you find out about her menstrual cycle, and then, that's a second confirmation to your diagnosis. Third, you take them to your scan room, you assess, you see the ovarian volume, you see the number of follicles, you say you have more than 12 follicles between 2 to 9 millimeters, she's PCO. The most important thing about Rotterdam is, now he has said you have got three criteria, correct? You're looking at hyperandrogenism, you're looking at the menstrual disorders, and you're looking at polycystic ovaries on scan. Now the criteria says you have to have 2 out of 3, which then divides the people who have been diagnosed to have PCO on 4 different phenotypes. And I'll tell you why I want you to just spend a thought on this. There are 4 different phenotypes based on the Rotterdam criteria. The first one, the most important one, and the most debilitating one is the frank or the classic PCO. Here you have all the 3 features. It's not just 2 out of 3, 3 out of 3. So if you have 3 out of 3, you have the classic or the frank PCO phenotype. And then you have the classic non-PCO type, wherein you have the hyperandrogenism, you have the menstrual disorders, but not PCO ovaries on scan. And then slowly the severity falls down to non-classic and the non-classic mild. Why is it important? Because the women with the frank phenotype who have all the 3 issues that we are talking about have a worse profile of metabolic and cardiovascular risk factors. You have a higher insulin resistance and a poorer lipid panel. And this obviously increases your morbidity. And what is very important is that women can move from one phenotype to the other. So if on your diagnosis this year you have a woman who's a non-classic ovulatory PCOS in which she's got regular menstrual cycle, she's got polycystic ovaries on scan and hyperandrogenism, but she's got ovulatory cycles. So you say fine, it's not that bad yet. But it's very easy for this woman to move from this phenotype to the more classic phenotypes. So this is the reason why when you see a woman in your clinic and you diagnose any of these phenotypes, you have to arrest it or make her phenotype better. What are the pitfalls and precautions during your investigations? Mostly whenever you have women who have irregular periods, the first thing anybody would do is put them on the pill. Well, you'd have to see that if she's on the pill the month prior to your testing, you cannot test her immediately after. You need to give her at least a month or 2 break before you do an assessment so that your assessment is accurate. Definitely measure her BMI, even though your Rotterdam criteria does not ask for it, you need to do that. You need to do a fasting lipid panel and a 2-hour glucose intolerance test, wherein you will call them impaired if your fasting is more than 110 and your 2 hours is more than 140, and you'll call them type 2 diabetes if the fasting is more than 125 and 2 hours is 200. Always, always, always check the blood pressure and always rule out hypothyroidism and hyperprolactinemia, which is great associations of PCO. Obviously, we have to rule out the related disorders of hyperandrogenism. Now, when you're doing hyperandrogenism, the common questions that keep getting asked is how do we detect it? Well, the idea is that they have raised testosterone, yes, but detecting free testosterone, which is what causes the manifestation, is very difficult. So what people have been doing and what has been advised is measure the SHBG and the total testosterone and then derive at the free testosterone. DHEA also is increased in PCOS as well as androgen tumors. No role of doing androstenedione, and SHBG is also a marker for androgen excess and insulin resistance. But when we're really looking at hyperandrogenism, I would also want you to know that you might have a woman who looks definitely hirsute, and you have done the androgen profile at the appropriate time, which is done in the early morning, and it has been done by a good lab, but the results are still normal. But you look at her and you say, no, she has to have PCOS or at least raised androgens. Now this is where it has been said that there is an individual skin sensitivity that determines the presentation, which means that you might have raised androgen but still not be hirsute, or you might be hirsute but not have raised androgens. So there is a kind of conundrum here which we'll have to know of. So just because she's got raised androgens doesn't, I mean, if she doesn't have hirsutism, doesn't mean that you don't do androgens. And 10 to 15% of hyperandrogenic women with apparently normal cycles, which means that they have regular withdrawal bleed, they might still be anovulate. Because our concept is what? They have regular periods, obviously they are ovulatory. But when you're looking at hyperandrogenism, they might have regular withdrawal bleeds, but they'll still be anovulatory. Ultrasound, the practical considerations that we need to know about is if you're seeing a corpus luteum or a dominant follicle, wrong time, you'll need to do it in the next cycle. Ideal, TDS. Ovarian volume, 10 ml. And the reason why I am emphasizing about this one particular aspect is, it is not always possible for everybody to actually count the follicles accurately. It could be because of the body habitus that you don't get a proper visualization. So what they say is at least do the ovarian volume. If it's more than 10, PCO. And also this is an extremely important thing to remember in adolescent girls wherein you can't do a TDS. The last thing and the most important thing is during your scan, always cast your eye at the endometrial thickness. What is it the offing? Well, you know, you're going to have a workshop this afternoon which is going to tell you a lot about ultrasound and its advancements and 3D. Now, 3D ultrasound machine is common in every gynecologist's office. And when you actually put on a 3D probe, you realize that this concept of Rotterdam, again, which was 14 years ago, was talking about 12 follicles. You do the 3D, you will see at least 25. And there is a plan of actually changing the concept of 12 follicles to possibly higher, up to 25. And there's also a probability of including AMH in your diagnosis of PCO. What are the additional features of PCOS? Obesity. But here the most important thing is not the obesity that is actually visible to you. The detrimental obesity that causes all the metabolic features of PCO is the abdominal and the visceral fat, which is not visualized. So just because you see that the BMI is okay, that doesn't mean that she doesn't have the features. It is the abdominal and the visceral fat that is the trigger point here. But obesity as well as androgen excess facilitates the insulin resistance. What is the impact? Well, the impact is obviously they are at a higher risk for metabolic syndrome, and there's an impact obviously on your insulin as well as the impaired glucose tolerance as well as the progression towards type 2. And when you really look, they have a higher chance of becoming impaired with the GTT at the tune of 30%. And type 2 with a tune of about 7.5 to 10%. And even again, here also, if we do not control this disorder, the rate of progression can be as high as 5 to 15% in 3 years. So this is where I say as gynecologists, it is very important for us to be aware of all of these things to control it. Dyslipidemia, they all have a very poor atherogenic lipid profile. There's elevated levels of LDL, triglyceride, cholesterol, and decreased level of LDL. They're also at a higher risk of developing atherosclerosis, arterial stiffness, altered vascular endothelium. And all of these obviously increase your cardiovascular risk profiles. Now, when you're looking at metabolic syndrome, you need to diagnose women to have metabolic syndrome if they have any 3 of these 5, which includes the abdominal obesity, the waist circumference being more than 88, triglycerides being high, HDL being low, blood pressure being high, fasting and 2 hours like we were talking about. It's not, these are the routine things that we have actually been taught in school and college and everywhere. But when we are talking about other disorders, there's not a lot of focus being put on the other additional things which are actually causing another impression and a lot of impact on these women who have PCO. The first thing is sleep disorders. There's a lot of obstructive sleep apnea in these people because of the obesity. And it starts as early as an adolescent. So can you imagine this poor child having to have such a burden right from the start of their life? And overall, the sleep disordered breathing and daytime sleepiness appears to be at least 2 to 3-fold higher in the obese PCO people. Now, there's also a lot of psychological well-being, and I think this is one factor which we are possibly not very, capable of handling. We can look after their insulin resistance, we can look after their hyperandrogenism, we can look after their cycles and everything. But when it comes to the psychological well-being, we are not very equipped to do that. But then, PCO does require a multi-speciality approach here. You will need a gynecologist, you will need a pediatrician in that age group, you will need a nutritionist supplementation and an exercise specialist as well as a psychologist. And I think this needs to be really taken on board. Why? Because there's so much that is associated. Depression, anxiety, increased recreational drug use, disordered eating, and psychosexual dysfunction. Now I'm talking about the problems for the last 10-15 minutes. But my boss always used to say, don't come to me with a problem. You come to me with a solution. So find a solution and then you tell me the problem. But don't come to me with a problem. I'm not going to find a solution for you. So I wanted to do the same. I've told you the problem. But let's talk about the solution as well. But to find a solution, we need to go to the beginning. What is the beginning? The evolution. We have to know where it's all starting from, because that is where we are all going back. In fact, I was just saying that possibly in a few years' time, we are all going to leave the cities and go to the villages because we have had enough of city life. But anyway, going back to the evolution, let's look at PCOS and its intrauterine environment. There is something called as fetal programming. I'll explain what fetal programming is. Now, what tends to happen is the fetus intrauterine is exposed to all the factors in the background of genes and in the background of environmental factors. This together causes the baby to be born small for gestation. There's a possibility the baby may be beyond the weight also, but that is also because of stress levels that the fetus has been exposed to. Then, during its progression towards adolescence, hyperinsulinemia, visceral obesity, adipose tissue dysfunction, premature retinarche, pubarche, PCOS, irregular cycles. Slowly, as they grow older, infertility. As they grow older, diabetes, hypertension, obesity, dyslipidemia. Once they cross over and become perimenopausal and menopausal, cardiovascular risk factors, endometrial cancer. So you see, it hasn't left any aspect of our life. Right from the fetal aspect to the menopause, it has affected every aspect. So what do we mean by this fetal programming? Well, there's a lot of steroids that are raised during stress. It could be because of the excess glucocorticoids or also because of the maternal androgen levels that are high. Now this causes the child to be born for small for gestational age or large for gestational age. Now the progression, as we have said, is right from then on towards adolescence and towards the end too. Now certain risk factors with the genes that we were talking about can lead to signs of premature puberty. If you have noticed even now, every generation, children are becoming much younger when they start their periods. We haven't changed much. Yes, the environment is changing, genes are changing, our lifestyles are changing. But if a child can have an early menarche, possibly there is some association to how it was during the fetal life as well. So premature puberty, premature adrenarche, metabolic syndrome. So in the peripubertal period, what tends to have is there's increased levels of leptin, hypersecretion of LH, and ovulatory cycles. Now, what is the prevalence? 3 to 25%. Again, this is a very difficult group to diagnose PCOS. Why? Because most of the girls during their menarche will have irregular periods. So how will you know whether it is PCO or whether it is adolescence? Acne, again, a lot of girls will have this problem. High volume ovaries, again, adolescent may have multicystic ovaries. So how do you diagnose it? Here, Rotterdam criteria doesn't work. You can't say 2 out of 3. Here you'll have to say 3 out of 3. These girls have to have all the 3 features. Only then you will call them PCOS. But another most important thing that you'll have to do is you cannot diagnose an adolescent to say that she's got PCOS unless she has at least 2 years post-menarche. Because for the first couple of years, there will be irregular periods. If she continues to have irregular periods beyond 2 years of her menarche, only then will you say that she's got PCOS. So always remember this 2-year period. Again, this is an extremely important time for you to evaluate her in terms of her metabolic issues, very important in terms of her psychological and dermatological issues. Because you don't really want this child to grow all the way through with these kind of burdens in her head. Oligomenorrhea, approximately in 75% of the women. Acne and hirsutism in about 60 to 70% of the women. And at least 18 to 24% have some degree of abnormal glucose metabolism. So what I'm trying to emphasize here is just because she's a girl, she's a young girl, Do we really need to do GTT? The answer is yes. If she's got obesity, do you really need to do lipid profile? The answer is yes. How do you treat them? You will hear this very often when it comes to PCOS, and that is lifestyle changes. I think the basis of the treatment and the condition is lifestyle, and this is something that is applicable to every stage of her life. In adolescent, lifestyle changes have to be approached and looked at. The second thing is OCP, to control the symptom of hyperandrogenism, and metformin actually plays a great role. This is a great drug to be used in this group of women. Now, metformin can either be used as a monotherapy, or you can combine it with your OC pills or anti-androgen medications. So in lean adolescent, what is the dose of metformin that you can go with? 850. If they are overweight, you can even go up to 2.5. And based on their symptoms and what you want to control, please add on other anti-androgenic medications such as spironolactone, flutamide, finasteride, and if metformin by itself is not enough, go for pioglitazone. But it's very important to know that this drug can be used to prevent or delay the progression to PCOS in the high-risk prepubertal girls. Give them for at least 6 months for you to notice any change. The most common anti-androgenic, or rather the low androgenic progesterones, are clonidinol and prosperinol, which is what Yasmin and Yaz have. And that is what we are commonly using. But a word of caution here. Yes, they have got the least androgenic properties, but they also have a possibility of causing venous thrombosis. And just to give you an idea about venous thrombosis, subjects with PCOS have 1.5 times higher baseline risk of venous thrombosis. And when you're giving them OC pills, there is at least a 3 to 4-fold higher risk of thrombosis. That is the reason why metformin is so important. That can be used as one of the options. And again, like I said, a minimum of 9 to 12 months to see the difference in terms of androgen excess. You have various other drugs like spironolactone, cyproterone acetate, flutamide, the doses and everything is there. Now, we've spoken about adolescent group. Let's look at the fertility aspect. Now, there are a few things that I also need you to understand about PCOS and fertility. We always worry that, she's got irregular periods. I have a lot of mothers coming and saying, she's got irregular periods now, will she be able to conceive later? I think these 3 points are very important for us to tell them and tell ourselves. Is that they may take longer to conceive, but if you really look at their lifetime achievement of pregnancy, it is no different from somebody else. So it's only the time that they're taking to conceive that's slightly longer, but their chances are still good. And it's only women who have obesity and PCOS that are at risk. Also, reason why we have to tackle it when they are younger. And what we've also seen is that when you have a 40-year-old woman coming and say that they want to conceive, we shy back. 40, you really want to conceive? Don't shy back. Do a scan. If she's got polycystic ovaries, she still has a chance. If she doesn't have a chance. So in some ways, it is helping. Now this is the commonest algorithm that we look at to treat fertility. And it's very concise and very simple and easy to follow. Again, like I said, first is weight loss. The second is the drugs that we use. Now, the first rule towards fertility though is to optimize her health before commencing treatment. And why am I emphasizing this again? We spoke about the evolution. Unless the mother is healthy, how is her child going to be healthy? You're creating another generation of people there. So it is your responsibility that the mother is healthy before she starts conceiving. Correct? So it's important that you optimize her health before she conceives. Those who are obese, weight loss has to be emphasized, and not just emphasized, enforced. In fact, we do not treat people if their BMI is anything above 30 to 30. Unless I put a stop to it. They might find somebody else to treat them. Fair enough, but I don't want to be contributing to the problem. Weight loss. We keep saying 5 to 10%. Why 5 to 10%? Because this actually reduces 30% of their fat in the visceral region, which we said was more problematic. Drug therapy, you're allowed to use orlistat, bariatric surgery. Bariatric surgery has been there in the scene possibly for the last decade, but we are still not very comfortable with the idea of bariatric surgery. I think we have to take away that screen away from us. There is a role of bariatric surgery. If there's a BMI of more than 35 associated with metabolic syndrome, they need bariatric. If the BMI is 40, definitely need bariatric. And if you really look at the difference it has made in people's lives, the incidence of PCOS comes down right from 45% to just 7%. And look at the infertility. It's reducing from 8% to 4%. So even though I'm an infertility specialist, I would still say, if you have a woman that is above 35 with metabolic syndrome, 40, go get bariatric. Most of them conceive. They come back to us at least to tell us that they've conceived. 80% of people who have gone towards bariatric surgery will not meet fertility treatments. Why? It improves your endocrine profile, improves the likelihood of ovulation and having a healthy pregnancy. So now we are talking about weight loss. Let's look at the others. Clomid, first line, cheap, easy. I'm still not very sure about this first line because I'm a great fan of letrozole, and thankfully it's back again in the market. But when we are really looking at Clomid, 75% of ovulation, pregnancy in only 35%, and at the end, this is what we really need to know, is 25% of Clomid starters will have a singleton live birth. So only 1/4 of the people that you're prescribing Clomid to will end up with a live birth. The recommendation, very important, is 6 Clomid cycles. You know, the age and the kind of environment we are practicing medicine is changing, as we have recently seen in the newspapers as well. There will be a time when we'll be held responsible for every prescription that we are giving. So please be aware that Clomid should not be given for more than 6 months. Let's start to adapt this. When do you stop Clomid? 6 ovulatory cycles, she hasn't conceived. When no ovulation occurs, even with 150, you stop Clomid. If your endometrium is of concern, you stop. Resistance, yes. Give them DEXA, give them dopamine agonist. If there's galactoria, give them metformin. If there's failure, please look at alternatives. The alternatives, like we were talking about, is letrozole. Now, there's a lot of these adjuvants in the market. Metformin, myoinositol, melatonin. Metformin at least needs to be given for 3 months before you're noticing any effect. What does ESHRE say? It's not making any difference to your live birth rates. So there is not much information when we're really looking at metformin. We are saying that it's not improving live birth rates. So when do you give metformin? Let me clarify that. You're giving metformin when women are resistant to Clomid, when their BMI is above 35. When you're taking them through IVF and you need to reduce OHSS, and when there's hyperandrogenism. So there is a role for metformin in fertility. What about myoinositol? I'll conclude with just one meta-analysis which said that it is showing improved treatment outcomes, but again, we need more data on this. Melatonin, initially I said there was oxidative stress as one of the reasons for PCOS. What does melatonin do? It reduces the stress. So coming to the other algorithm, if they fail with oral medications, it's gonadotropins as the next step. And what does gonadotropin tell you? Sorry, I think I'm going very fast. What is gonadotropins? Well, one aspect that I need you to know about gonadotropins is there is no difference in your pregnancy rate or live birth rates, whether you use HMG or whether you use recombinant. So look for the cheaper drug to help this woman conceive. Laparoscopic ovarian drilling. I think the one word that I will need to tell all of you is we have slowly moving out of this phase of doing laparoscopic ovarian drilling for everybody, and thankfully. Why? Because we are still seeing a lot of people who were diagnosed as PCO, who had ovarian drilling, are coming back to you a few years later with very low reserve. So please be careful in terms of deciding who needs laparoscopic drilling and how do you do it. It's the rule of 4. 4 punctures, 4 seconds, 40 watts to the depth of 4 millimeters. But when does it actually work best? Ovarian drilling works best if she's got a normal BMI, if she's got a shortened fertility period, and if her LH is high. So you can't take a big woman and put her on the operating table and say this is going to work. It won't work. Again, the reason why we said lifestyle changes before you even commence anything else. Forget. When do you do IUI? Obviously when there's male factor and who haven't conceived after 6 cycles. IVF when you have other factors. Just to summarize, if you have a weight loss of, and if the BMI is more than 27, you look for weight loss. She still hasn't conceived. CC for 6 cycles. She's ovulated for 6 cycles, not conceived, CC failure, gave her gonadotropins for 4 to 6 cycles, she still hasn't conceived IVF. So if you really look, the fertility journey should finish within 18 months. How often is it that you see people who have been diagnosed to have PCO finish their fertility journey in 18 months? You don't. But we need to control this. We need to control the kind of gonadotropins, injections, tablets, and whatever treatments you're offering, because the success rates are high. What do you do if she has lost weight, she's still not pregnant, you have tried Clomid, Clomid hasn't worked. So it is Clomid resistance. What do? You add metformin. You go on to gonadotropins, still not conceived, IVF. Again, you've got her pregnant through your fertility treatments. What happens in the pregnancy? Well, there's a higher risk for GDM, placental abruption, eclampsia, and they have to be screened for hypertension and diabetes prior to them becoming pregnant. A word here about metformin in pregnancy, and this meta-analysis, which is very recent, has actually said metformin use in pregnancy has increased the possibility of a term delivery, vaginal delivery, reduces the risk of early pregnancy loss, preterm labor, pregnancy complications as GDM and PIH, and with very minimal side effects. So what they are actually doing is they're recommending metformin not just for the adolescent, not just for the fertility issues, but even in pregnancy right now. Now let's look at the age group that I come from, older women. They have, yes, PCOS may still be there, but here the Ferriman-Galway score is much lower. But if you compare a 240-year-old or 245-year-old women, even the ones with PCO might still have higher androgen levels. And what they have noticed is that these women, slowly as they get older, tend to have ovulatory cycles. Perimenopause, the most important group actually, is because they tend to have a more higher risk for cardiovascular disease, hypertension, dyslipidemias, diabetes, obesity, the dreaded conditions. There's also an association of plasma homocysteine with PCOS. And once there's raised homocysteine levels, there could be other associated CVD disorders. Always when you see a woman, irrespective of her age, even in this age group, it's very important that you look at the waist circumference, look at their lipid profiles, and also their glucose tolerance test. But one thing that is a bit heartening is that the estimated menopausal range of women who have got polycystic ovaries is about 2 years later than somebody else. So they still have potential to conceive, and the menopause is also pushed away. Cancer. Now, obviously, unopposed estrogen, increased risk of endometrial cancer. But there's still inconsistent data to tell us about the ovarian and the breast cancer risk. So when we're really looking at the management in these 3 different groups, I'll have to emphasize the most important thing is lifestyle, weight loss. And then in the adolescent, just to summarize, OC pills, metformin, reproductive age, if they don't want pregnancy, OC pills, and if they want pregnancy, go through the fertility treatments, perimenopause and menopause, please rule out metabolic syndrome. So, women with PCOS are at increased risk of obstetric, cardiometabolic, oncology, and the psychological complications. Yes, yes. So what are we going to do about them? We have again spoken about all the treatments, but I think now is the age that we have to stop them from progressing towards it. So we are really looking at screening. There are a lot of societies that have come back with some kind of data. And what they are saying is that do the GTT. If it is normal, screen them every 2 years. If it's impaired, every 1 year. Again, during the visits, if you notice that she's increasing her weight, or if there are other features that are adding on, you might need to do the screening much quicker. But at every visit, it is very important that you're checking their BMI, you're checking their waist circumference, checking their blood pressure, and lipid profile. Now, you would also classify women in this age group, in the perimenopausal age group, to be at risk and at high risk. At risk is when they have any of these features like obesity, cigarette smoking, hypertension, dyslipidemia, vascular diseases, and insulin impaired glucose tolerance. And high risk when they have metabolic syndrome or type 2 diabetes. Moreover, depression, anxiety disorders are risk factors for CVD as well. It is not just what we have spoken about in terms of metabolic syndrome, but these things are not discussed as much, but has, like I said, have great impact. That is the depression and the anxiety, and that also has to be taken into account. Screening for cancer, again, there is no guideline for screening these women. It's only if they come with a problem in terms of abnormal uterine bleeding will you assess them. But there is no screening protocol that has been advised. Need of the hour, current diagnostic guidelines are still very vague, aren't they? Like we've discussed. They might not be able to detect all the patients that are walking in who could be a potential PCOS with their ramifications towards their life even up till menopause. So what we really need to do is update, unify guidelines, and also provide an appropriate rationale and diagnostic tools for them. Thank you very much.
Totally. Maybe you have to follow the intrauterine life. Start from the intrauterine life. And so for IUG, baby, you should start following that baby continuously. Maybe after delivery, we forget about the babies and the mothers also. Even after conceiving, infertility, PCOS, they conceive. They don't come to us, we don't advise. So according to her, we have to advise these patients to follow continuously, even after menopause, post-menopause age. Continuous follow-up is very essential. Maybe
many patients coming with as first line therapy, they do ovarian drilling. I think we should say that's not the first line therapy. Go with other drugs, and only when they don't conceive, we should consider that. Because we are seeing young girls being subjected for ovarian drilling and coming on, and they just leave the patient without advising or giving following up with some CC treatment cycles. They just do the drilling and leave the patient. They come after 6 months, 1 year saying that the doctor said you'll conceive by yourself. But I think that's going to be a waste, and we are reducing the reserve.
In fact, there was one slide which I forgot for the lack of time. There's a lot of awareness when it comes to ovarian drilling. We went through this phase where we didn't know what it was doing. We said, oh, we know what it's doing, so we went and did drilling for everybody. And then slowly, I think we are on that plateau where we are, and hopefully, we will slowly decide that there are other better modalities to actually treat. The only reason why we will do laparoscopic ovarian drilling is you have a woman who lives in the outskirts. She can't come. She can't afford gonadotropin injections. She cannot come for regular monitoring because that's what you need for gonadotropin. The oral medications don't work. So it's only in certain group of people that you might consider. But again, if they do not conceive within 6 months of ovarian drilling, they will have to come back into the fertility treatments and not wait. Sorry, Lakshmi.
In adolescent, you said OC pills.
Correct.
How long?
See, again, this is where we were talking about OC pills. If you're giving drospiridone and clonidone, I was of the opinion they're very safe. But actually, data is showing that there's a higher risk of venous thromboembolism in these group. And if this adolescent is overweight, their risk is higher. So this is where metformin is actually so safe. And metformin, even though it is not very effective in other features like hirsutism and acne, a lot of that, there is some effect. So if you want, you can use, if you are at risk, if the child is at risk for thromboembolism, give her metformin. You can add other anti-androgens, spironolactone, very simple. Give her spironolactone with metformin, still doesn't help, then add on OC pills. And you need, for it to make a difference, you need to give it for at least 9 to 12 months. And once, correct, unless you will not see a difference, because see, adolescents, they are very conscious about their image and hirsutism and all of that. So for them to make a difference, it will take at least 9 to 12 months. But now you also have Vanika, the cream, the effervescent cream. That also should be added on. So you know you will have that. That's a cream, a topical application. That is anti-steroid. Sorry, anti-androgen. So that's used and it's available now. So you can use that as well. So it's actually getting a few things together to try and improve the thing. But OC pills, good, but we have to look at the risk factors.
Giving estrogen in adults will not hinder their
Correct, we are not giving estrogens. You're talking about the pill? We are talking about adolescents once they're crossed and come towards menarche. We are not talking about before their menarche.
before 16 years, we usually avoid it.
If usually by the time if they started their periods, normally their growth potential doesn't depend that much. And the dosage that you're giving, the estrogen that you're giving is microdoses. So there's not much of an issue in that regard. Correct. There's always a side effect.
Regarding ovarian drilling, wherever there is laparoscopy is there, people are doing ovarian drilling and burning, flat burning, tearing. It's a lot of damage, but please, but the message should go across the, maybe some pamphlet, something you should be
I
given.
don't know, Dr. Pedagog.
Venkat.
I thought we are getting better, in terms of educating people, and gynecologists seem to be having a more clearer idea about drilling the aspects nowadays.
Audience. Thank you, Durga, for the invitation. I think nowadays the scenario is better than what it was 10 years ago. As Madam rightly said, everybody was burning it as a chicken 65 earlier days. I do agree. But I think the awareness has come in the gynecologists, and people are doing lesser and lesser number of ovarian drilling. The guidelines are very clear. If at all you do the drilling, only 4 to 8, not more than that. Some more refined tricks are, take the puncture needle, not that conventional hook which general surgeon uses for everything. The monopolar, it causes more damage because lateral thermal damage is more with the hook. If at all you want to drill the ovary, take the needle and just near the ovary, you start your pedal, then prick it. Minimum damage will be there. 4 will do, your maximum limit is 8. Please don't do beyond that. You are destroying thousands or millions of ova. Second thing is, have the irrigation immediately in your hand and irrigate the ovary, cool down the ovary. You have stimulated, but you have minimized the thermal damage. These are the things I feel we should remember whenever we are doing the ovarian drilling. One more point, if I am not exceeding my time, Dr. Durga, please never ever try to remove the ovary when there is a torsion ovary. Torsion ovary, however dark, brown or black it looks like, have patience, untwist, wait as long as 30 to 40 minutes. It is going to improve in the color. Even 10 to 20% improvement in the color, believe me, it will be viable. It will not get necrosed, the patient will not go into septicemia. Gone those days where we used to not even untwist, clamp and remove when we were doing open surgeries. Believe me, untwist, save the ovary. The woman may need her ovary anytime in her future. Thank you.
A very good paper published in Journal of Clinical Ultrasound, where they have done a very good work on a tossed ovary which has been saved, and the follow-up of those ovaries where the vascularity has been re-established. So just because it is tossed, there is no reason why we should remove. And positively, there is a very huge study which has been done. Almost they did about, I think, 600 in dot cases, where they found that all the tossed ovaries which were untwisted, they were viable.
Thank you, sir, for sharing there. And Dr. Ashok.
Hi, I am Dr. Ashok. It's very nice to have from Chennai. But it's really good that the people of Vijayawada are so concerned about AFC, ovary. I really admire this. I want every state to do this actually, and this is what I always say. But now coming back to this, I have a question for Durga. When we are stimulating these PCO patients, we all know, 20, 25 is an honeycomb appearance follicles, and 30% of the population fall under CC resistant. Luckily, we have letrose today. But in case if the letrose was not there, then we had the other option was either LOD or gonadotropins. Now in gonadotropins, what we find typically is some all or none phenomena. I give 75, nothing comes up. I give 150, suddenly everything comes up. So how do you actually tackle these group of people? How do you make it come only 2 or 3 follicles, not going into HSS or not going into
I'll be going back towards the starting. Again, if something is wrong, you'll have to look back. Why is it wrong? It's wrong either because you have ignored. So if you have people who are resistant, you have to look at the reasons for resistance of clovin or any drug for that matter. The most common reason is BMI. We haven't tackled her BMI. The second common reason is hyperandrogenism. This is where you might have to use dexamethasone. You might have to use metformin as well. Leave them on metformin, get them to lose weight. If you require, put them on orlistat, put them on metformin for 3 months, 4 months. That is better than them coming to the situation that you're talking about. Because it's easy for us as fertility specialists to deal with it. They have excessive things, we'll say what? Okay, let's convert it to IVF. But that's not possible for most of us. Correct? As fertility specialists, we have options, but that's not an option that is available for everybody. Which is coming back to the same question as virgin's control. Look at these things and only then I think we should take them towards fertility.
So excellent. So you mean you reduce the BMI, probably add them on DEXA, metformin, adjuvants, give a try for 3 months. And okay, then you try that, and unfortunately, she lean PCO is sitting in front of you, you can't even see her.
Lean PCO, laparoscopic ovarian drilling, given the
excellent. Yeah, and that criteria is very important because the latest consensus by one is she should be lean, her BMI should be low. If the BMI is more, don't do drilling. Her LH should be at least more than 15 to respond. If it is less than 15, the success is less. And
the duration of infertility.
yeah, the duration of infertility should be less than 5 years. Means the more, there is other associated factor. So these are only 3 proven factors which is same. Okay,
So
and
thank you,
then
Dr. Ashok.
only one question.
Stalling for
Only one
Sorry,
question, because
madam.
I think this is very much needed for the IUI people. You said that there is HMG you can start because the statistics say that there is no difference between HMG and recombinant. Yeah, fantastic, right? But I feel particularly in PCOS, the problem what we lack is this one. Like, the threshold of the follicles is different. So, for few group of people, do you think that recombinant is better where I can titrate? I can come even 37.5, I can even give 50, or I can even give 75 because I have the choice of only 75 or 150 in this. So, do you think few people will be helpful for
if you
that?
look at the traditional people who, low dose protocol, 37.5 every day, how many of our patients are going to take injections every day? I would rather they go through IVF. So, it is what is, yes, theoretically what you're saying is fine, but practically I don't think that is something that is actually suitable for a lot of people to come every day and take those 37.5, because my women refuse to take their injection themselves. How much ever you want to empower them, tell them, take injections at home, they don't. They will travel however long it takes to come and take your injections. So every day there's little doses, you're right. It will help in terms of monofollicular and sometimes just to get the follicles that you want. But the practical and the logistic situation may not be.
Yeah, the duration is high.
Absolutely.
Thank you.
Thank you, Dr. Ashok, and thank you, Dr. Durga.
Thank you.
Madam, thank you for taking your time out. May I now request Professor Ramadevi Garu to felicitate our keynote speaker, Dr. Durga Rao, for today. Thank you, Madam. That was a lovely lecture that we have had, and thanks for enlightening all of us.
There.